Can we start?
Sure, we can.
Yeah. Okay. Good evening, ladies and gentlemen. I'm glad to be with you again. Before to start, thank you, Dr. Hatem, for making this available. And tonight we'll try to cover and discuss some testable concepts in electrophysiology, hemodynamics, and some basic cardiac physiology, some clinical syndromes, and also some hemodynamic tracing. So please feel free to ask any questions. And I mentioned before, it is not one-man show, it is interactive sessions. So please, we need to hear most of the voices or all of the voices in this meeting. So let us get started. Now we stopped in the question number 10, I think. Yes. Number 9. So can anyone read the question and try to answer all of these? The following questions, the next a couple of questions are very basic questions. It is just regarding the projections in the cath lab.
Saleh, we don't see any slide yet apart from your first one.
Okay, so I will stop sharing and share it again. So, okay, we'll start share again. Do you see my slide now?
Yes, now we see it.
Okay. Anyone can start?
Okay, you can read it, Muawiyah.
Go ahead, Maawi.
Okay, which of the following projections allows the operator to best visualize proximal left circumflex stenosis? Is this 30 degree RAO, 30 degree RAO, 30 degree cranial, 30 degree left anterior oblique, 30 degree cranial, or 30 degree RAO, 30 degree caudal?
Yes, but any projection can best visualize proximal circ. Usually, the proximal coronary arteries. Yes. RAO, which RAO?
Caudal views.
RAO caudal.
Yes.
Okay. This is a straightforward question. Nothing. You can read. I will leave this slide for you. You can read it in your own time. For sake of time, we'll go through these short STEM questions fast to catch some and discuss some questions which need some more explanation. So, question number 10. Okay. Time يا شباب. Time يا شباب. We have limited time.
Question number 10. What percentage of individuals with aortic valve have dominant coronary circulation? A 1%, B 10%, C 30%, D 50%. I think
How much? How much?
30%.
30%. Excellent. About 10% only of right dominant of the individual of right dominant, the posterior descending arises from the distal circumflex. However, 30% of patients with bicuspid valve have left system, which is left system dominant artery, which is usually left circumflex with patients with bicuspid aortic valve. But general population is about 10%. But in population bicuspid aortic valve, 30%. Okay. Question 11.
Okay, I can take it.
Yes, please.
Okay, in order to obtain a spider view to better visualize left main,
What's your name,
left
doctor?
anterior descending. Muawiyah.
Muawiyah again. Okay.
Yes. Left circumflex view, the radiographic technician should be directed to position the image intensifier to 15-degree REO, 30-degree cranial, 30-degree REO, 30-degree caudal, 50-degree LO, 35-degree cranial, 50-degree LO, 20-degree caudal. The answer is D, 50-degree LO, 20-degree caudal.
20-degree caudal, huh? Good.
LO, yes.
Usually the spider view is iliocaudal. Okay. Question number 13.
I can take it. Question number 13. Coronary venous oxygenation saturation is typically A 30%, B 50%, C 65%, D 80%. I choose A 30%.
Yes. This is the lowest venous oxygen saturation in the body, which is usually ranging from 25 to 35%. Do you know why? Okay, think about it. Well, this is very basic. We'll answer it at the end of the session, inshallah. Think about it.
30%.
Yeah. Can you answer?
Yes, 30%. A.
Yeah, I know. 30%. Why 30%? The other part of the body usually about 70%. And the coronary venous saturation, oxygen saturation is 30%. Why?
Oxygen consumption more in myocardium.
Yeah, usually in the myocardium there is maximum oxygen consumption at rest. Excellent. يلا هو answer the question. أشواق ولا صح؟ ولا who's the answer? Who's the one?
The finding on the chest radiograph shown would be associated with which of the following measurement on device interrogation.
Okay. Before to go through the device interrogation, the options of device interrogation, what did you notice in this chest X-ray? What did you notice in the X-ray? What's the abnormality in the X-ray?
Right side.
Okay. Can you raise your voice, please?
There is a RV.
What is this?
Leads.
What is this? What is this device?
CRT, 3 leads.
Okay, excellent. CRT what? There is CRT-B and CRT-D. What is it?
I don't...
Okay, CRT, the resynchronization can be used with defibrillator or just pacing. Defibrillator, you will see a RV coil or SV or RV and SVC coil, which is thickened coil within the RV, but it is not there. So likely this is CRTP. Okay. Anyway, as you mentioned, there is lead. What is wrong of the lead? What's the problem in this lead?
It's broken.
A fracture, lead fracture.
Lead fracture. Excellent. So when the patient presented with lead fracture and you interrogate the device, and the device regarding this interrogation with considering threshold and impedance will be what? Is it high voltage threshold, high lead impedance, low voltage threshold, high lead impedance, high voltage threshold or low lead impedance, low voltage threshold or low lead impedance, or high voltage threshold, normal lead impedance? Which is the right one? If someone need to answer, he can answer in the chat. If you want to answer.
This is lead fracture.
The low voltage threshold, low lead impedance.
Yani which one? B or what? Or
Low voltage threshold and high lead impedance.
yani, which one? B.
B.
No. Usually fracture, everything is sky high. Any fracture, sky high. Anything high. So what is the answer?
D. Sorry.
A.
C.
Usually, if there is any fracture,
A high
yeah,
voltage.
high voltage and high impedance. We should discuss what is the impedance, what is the threshold. Unfortunately, I promised to present to you the basic stuff of pacemakers and ICD, but we don't have time. But in future, if we have time, we can discuss some very basic stuff about the devices. So I collect this abnormality in the device interrogation regarding basic threshold and impedance, and what are these abnormalities, and the etiology of each abnormality, either high regarding threshold and impedance. We'll find it in this nice table. Okay. Question number 15. By this way, we'll not finish even 10 questions. So we need to go fast. We need to, this is very straightforward question. No, either you know or you don't. Okay. Can anyone answer, or at least read the question? Okay. A meta-analysis reviewed the fate of moderate to severe MR in patients with in a large pool of patients having undergone TAVI or transcatheter aortic valve replacement. In what proportion of patients that the MR severity will improve post-TAVI or post-TAVR? Is it in 10% of these population, 30%, 50%, 70%, and 90%? Actually, it is in the
Yeah,
observational
actually 45.
randomized studies, the MR severity improve in about 50% of those patients. They are following a patient post TAVI in about 6 months. The most patients they get benefit from this when the MR, it's not the patient, the gradient, when the gradient across the aortic valve is more than 40, main gradient more than 40 millimeter mercury, and the patient in sinus rhythm. Those patients, they found most of the MR and also the etiology play a major role in the improvement of the MR severity. So these three factors play important roles beside the implantation of the valve through trans-aortic catheter. Some patients may be presented with moderate to severe MR accompanied with severe aortic stenosis after replacement of the valve by TAVI through the catheter. The severity of MR will improve in 50% of patients. Those patients, there is some criteria for them, which are usually the gradient across the aortic valve more than 40 millimeter mercury, usually the etiology of the valve, not some etiology only, not all of the etiologies will improve the severity, as well as the patient should be in sinus rhythm. Okay, this question is just a very basic question. Can anyone read it?
Okay. A 50-year-old man with posterior MI and ejection fraction of 38 was admitted for eccentric chest pain. Cardiac enzyme was negative, were negative. Aspirate and NIT scan show fixed anterolateral perfusion defect. Medication including aspirin, metoprolol, and lisinopril. During monitoring, tracing one was observed. The patient was asymptomatic. The best management option for this patient is A, amiodarone 150 milligram IV, magnesium sulfate 2 gram IV, episodic, implant and ICD, discharge home.
طيب, this is the tracing. Okay, what do you think, Doctora?
ICD.
Can you raise your voice, please?
This is VT during tracing.
So this is VT.
VT.
VT, huh?
Non-sustained VT.
Non-sustained VT. Okay.
Yes.
Okay. This patient, prior MI, ejection fraction 38%, anterolateral perfusion defect, amyloid scan, there is fixed. Nothing to be done on optimal medical therapy. So what is the next step? Shall we give him amiodarone, magnesium, EV study, implant ICD, or home? What do you think, Yarabab? I will show you. I will show you the tracing again. I will show you the tracing again. Okay. Free.
There is ROT phenomena at the beginning of the trace, at the beginning of the non-sustained VT.
Raise your voice. Your voice not clear.
It starts with ROT phenomena, the non-sustained VT.
Okay. So what do you think?
I think this patient for ICD.
For ICD. Anybody has any other opinion?
I will choose C and to do an EB study for him, for her, because the ejection fraction is above 35%.
35%. Okay. Any other opinion?
What? Hello?
Yeah.
EB study if in use for ICD implantation. Ejection fraction less than 30 ICD من 30 to 35 داير نيها class 2 3 above 35 to 40 EB study if inducible for ICD.
Okay. طيب, okay. I will show you the tracing again. Please look again to the tracing.
D point, magnesium sulfate.
Okay, magnesium sulfate. Why magnesium sulfate?
This is your third D point.
Okay. Any other opinion? No one choose amiodarone?
I think this is an artifact because I can see
Excellent.
some.
Who's this?
Yes, Muawiyah.
Muawiyah. Excellent, yeah, Muawiyah. طيب, explain to your colleagues. You are going to discharge the patient home, isn't it?
Yes.
Okay, I agree with you. But if this tracing, you should explain this tracing to convince your colleagues you are going to discharge the patient home. You are comfortable for this decision. Why? Explain to them.
Because there is, I can see some R wave here.
Excellent.
Within the.
Excellent. What's your level, Muawiyah? Okay, if you trace the R wave and this tracing, you will find there is R wave in between. Okay, here and here and here and here. So likely this is artifact simulating ventricular tachycardia. So you can march the R wave from the beginning of the tracing and even through this artifact. So I agree with the Muawiyah. He can be يعني discharge home safely inshallah. Okay. Are there any question at this point? If not, we will keep going. Okay. I'm talking to myself tonight.
السلايد ما تغيرت يا ولد.
Okay. Okay. Anyone can read the question? I will play the angio. Did you see the angio clear? Did you see the angio playing?
Yes, we see it.
Okay. Can anyone read the question and try to answer?
Which of the following is true regarding this patient condition? A, this condition is common cause of the sudden cardiac death in adolescent. The anomaly show a represent origin of the left coronary artery from the right. Surgical reimplantation of the anomaly coronary artery is indicated. Patient with this condition who survive post childhood often present with varying degree of heart failure, myocardial ischemia, MR, depending on the development of collateral circulation. This condition is usually inoperable and the best left alone.
Okay.
يا
طيب يا دكتور مين معي؟ دكتور
دكتور
حسن.
مبارك.
ها؟
حسن.
حسن. طيب يا حسن, what did you see in this view?
The LCX origin from the RCA.
The circ originated from the RCA.
Yes.
Okay. What is this view يا حسن?
Yes. RCA. Yeah,
What is this view?
Yes. The
This view.
ROO cranial.
RO.
Yes, this femina is Kaaba. Al-Kaaba retrograde من RCA.
Was it?
Kaaba. Al-Kaaba.
Can you, what is this Al-Kaaba?
Yes. A left system originated from the right, I mean, a right system.
Okay. Good. Excellent. So this is this is one of the rare congenital anomalies of the coronary artery, which is anomalies of the coronary artery coming from the pulmonary artery.
Yes.
If you look to this artery, the catheter is placed, the tip of the catheter placed in the ostium of the right coronary artery. And the right coronary artery, as you see in this view, is a tortuous, dilated tortuous coronary artery with multiple anastomosis with the left side system. The dye go through these anastomosis to the left side, and because of the pressure is high inside the left system, is go toward the low circulation pressure, which is the pulmonary artery, as you see here. If you see my artery, okay. So as you mentioned, this is yes, Al-Kaaba or anomaly if the left coronary artery from the pulmonary artery, which is rare. Usually, the patient suffers from the heart failure, myocardial infarction in in childhood. May presented with heart failure, ischemia, severe MR, which depends on the presentation of the collateral at that stage. So if there is any ischemia or MI in childhood, think of Al-Kaaba. Okay, so I think we answered the question. Thank you. The other name is Bland-White-Garland syndrome. Bland-White-Garland syndrome. Thank you. Anyone can read the question and answer? Try to answer.
الو السلام عليكم.
السلام ورحمة الله وبركاته. تفضل
دكتور
أخي.
صالح ياسين.
يا مرحبا ياسين، تفضل.
Question 18 is 26-year-old patient presented to A&E with the rhythm strips as shown in figure. He is complaining of palpitation and chest pain. His blood pressure was 80/60. So this figure shows that
what is the figure showed?
Yeah, the figure shows there is a wide complex. It looks irregular wide complex tachycardia.
Excellent.
Yes, and but it looks originated from the ventricles because the inferior leads, they are negative.
So inferior lead negative, likely from where?
Maybe ventricular.
Maybe ventricular. Okay.
Yeah, and there is RBB, so it's originated from the left side.
From the left side, okay.
Yeah, and there is a positive concordance also, which supports the VT. But usually, yeah, the concordance and the negative inferior leads, they are supporting the VT. But because usually the wide complex tachycardia, when it's irregular, usually we think about the pre-excited atrial fibrillation, patient with WBW with pre-excitation.
Okay. Yes, this is a pre-excitation.
Yes,
Pre-excited AF. Anyway,
from the left side.
anyway,
Yeah.
there is a. It is yes, wide QRS complex tachycardia with variable degree
Regularity.
of widening of the QRS complex.
Yes.
And there is completely irregular rhythm.
Yeah.
So
it is originated
VT
from
is
the
out. The VT is out. Okay.
Yeah. So it is
Usually don't mention the VT in like hood rhythm strips.
irregular. Yeah.
Is regular, yes. With you, you can mention this. Although some VTs can be slightly irregular, but generally speaking, the ventricular tachycardia usually
Regular.
the rhythm
Regular.
is regular.
Yes. So it is most likely originated from the inferior part, and the AVL and lead when they are positive. So it is from septal side directed towards the lateral side, most likely.
Okay. Anyway, this so very excited atrial fibrillation.
Yes.
Type. What are the? You said there is very excited atrial fibrillation. What's your evidence? Can be wide QRS complex tachycardia, which is atrial fibrillation. Why you said very excited?
Yeah, because in if we concentrate here in V5, there is a delta wave.
Good. So there is clear. If you look carefully to the precordial leads, you will find some QRS complex wide and some skinny QRS complex. These impulses can conducted the wide conducted through the some of these can conduct through the AV node, and the others, most of them can be conducted through the accessory pathway.
Yes.
If you look carefully to the V4 and 5, you will find there is a delta wave. Did you see my arrow? Did you see it?
Yes.
The delta wave. So this is classical question in any board in the planet. This question is classical because it is top emergency.
Yeah.
Anyway, patients with tachycardia, any kind of tachycardia with this blood pressure, you can choose directly cardioversion.
Cardioversion. Yeah.
So no doubt about this. Even if you don't get the diagnosis from the rhythm strip, but if the blood pressure is 100/60, what you will choose? Not from the option here. What is the best medication?
Procainamide.
Procainamide. Excellent. What other medication you can use it?
Disopyramide.
What is it?
Disopyramide.
Oh my God. No. It is procainamide, yes.
Yes, true.
What else?
Ibutylide.
Yes, excellent.
Ibutylide.
So the two medications in the guidelines can be used in patients with stable, hemodynamically stable, pre-excited atrial fibrillation are procainamide, the second ibutylide. If you don't, cardiovert. Previously, we used the amiodarone, but it's not there anymore. Thank you. Thank you, Yassine. Thank you. Okay. Anyone? I need to hear voice. I didn't hear it from before. Yani someone new. Okay, anyone, for sake of time.
Okay. So let me continue as the previous question.
No, I need someone else. يلا شباب. Okay. Go ahead يا ياسر.
Mubarak, what is
Oh,
the reason
مبارك
show?
تفضل يا مبارك تفضل يا مبارك
What is
تفضل
the reason
تفضل.
show in the figure?
Who is this?
AF with
Who is this?
exciting.
Who is this?
Yes. Yes.
Introduce
AF,
yourself, please.
yes.
Introduce yourself and start.
Yes. Mubarak.
مبارك
What
تفضل
is,
يا مبارك.
what is the reason show in the figure? AF with
Yeah.
very exciting RBB.
Okay.
AV NRT with aberrant. VT likely rise from the left ventricle. VT like rise from the right ventricle. Antidromic NRT.
Excellent. يلا. What do you think يا مبارك?
Yes, this is white QRX complex tachycardia.
Okay.
Positive R wave in V1, and there is a negative in V1, positive and negative R wave. The first is positive, and the second here is negative. The V1.
So.
Yes. This is likely rise from.
What is this? What is this?
Yes.
What is this again?
Yeah, this is VT.
Ventricular tachycardia.
Ventricular tachycardia.
Are you sure?
Yes.
What are your what are the things here?
Yes.
Telling you or telling us this is VT.
Yes, this is VT.
What are the things? Let you call this VT.
Yes.
What are the things? Why you said this is VT?
Wide QRX complex. And,
okay, wide QRS complex tachycardia. Good. Starting. Although all of the options can be presented with wide QRS complex tachycardia.
Yes.
So
and this is the inferior lead is negative.
So
the inferior lead is negative. This is from the base away from the inferior lead, and the button is RBB in V1.
Okay.
Yes. This is most probably VT likely rise from the left ventricle.
Anything else?
There is
No. I need Mubarak to talk. I will let you. If Mubarak finished, I will let you to comment. Okay, Mubarak, continue. What are the features? This is not enough to say this is VT. What are you talking? What are you talking about is localization, not features of VT. I need why you said this is VT. You said the inferior is negative. It can help a little bit. You right bundle branch block. It can happen in all of these kinds of arrhythmia. But what are the features in this ECG? Let you say this is VT.
Yes, this dissociation in this ECG is a sign
there is what?
VT. Dissociation.
What is the
AV dissociation?
What is it?
AV dissociation.
Okay, I can't hear you well, Mubarak, but I am trying my best. AV dissociation. Where is this AV dissociation? Can you show me? Just let me to go through any. So I will help you here. Do you want to go through the V1 or lead 2 or 5? Where are you?
V5.
V5. Okay. Yes. As Mubarak said, there is some B waves. If you see my arrow, the second, the first, and then the second, third is not there. There is other. There is, and the fifth one, there is B wave. If you go further, at the middle of the rhythm strip, there is B wave, and then there is no B wave. So there is AV dissociation. So AV dissociation, one of the features supporting you to say this is ventricular tachycardia. What else, What else, Mubarak? And this tracing supported the the theory or the hypothesis of VT in this ECG?
Excuse me, they are capture beats and fusion beats.
Who's talking? I need Mubarak.
Okay.
Mubarak is talking, so let Mubarak to finish. He is starting in a very nice way. He is answer tough question, so let him to finish. Actually, this is a very tough question, but in some way, but it is a straightforward question. There is some difficulty in some part. It is not in the general board, but it's okay. Type. Okay, we can let the other colleagues to contribute. Where is our colleague, Doctora? She's starting, and I stopped her. What's your name, Doctora?
Maha.
Maha. Go ahead, yeah, Maha. You are talking. Start to talk. I stopped you. Sorry for that. So he said there is AV. This is VT, and there is AV dissociation. Okay.
There is AV dissociation. Also
excellent. What else? What else?
There is a capture beat.
Where is the capture beat?
In lead 2, there is 2 beat.
There is 2 beat, which
normal.
Is usually there is even B wave in front of each one. This is very nice, beautiful, narrow QRS complex. Okay, these are capture beats. Type. Anything else? If you look to
there is also.
Is this beat?
Also, there is negative concordance in
before the concordance. Did you see my arrow?
Yeah.
Did you see my arrow?
Yes.
What is this beat? This one.
This is fusion beat.
Yeah, if you look to this beat, it is different from VT and from normal. It is mixed. So this is fusion. So this ECG, very beautiful ECG, capture the fusion and the capture beats at the same time. So this is fusion and this is capture beats, AV dissociation. What else?
Negative concordance in the chest lead.
How negative concordance? V1 is positive. After that, negative. There is no concordance.
From 3 up to 6.
No, the concordance, what is the meaning of concordance? From all of the precordial leads on the same direction, either positive or negative, starting from V1 to V6. So there is no concordance here.
Okay, the positive AVR is go with the
excellent Freaky criteria. If you heard about Freaky criteria, the positive, very R positive. This is indication of this is something coming. Okay, so this is toward the electrical activity, and the axis of the VT is toward the AVR, which is significantly there is R's in the AVR, with supporting the hypothesis of VT. What else? Okay, this is, if you look to the B1, is it typical right-handed or atypical? It is atypical because it is monophasic. Monophasic R wave, so it is atypical. This is also supporting the hypothesis of VT. If you calculate the duration from the beginning of the R to the nadir of the S here, this, you will find it more than 100 milliseconds because each small square is 40. So this is 6 by 40 to 140. So 240 milliseconds. So this is Brugada sign is positive. Always be systematic in evaluation of wide QRS complex tachycardia. Start by learn what we call Brugada.
Sorry, sir.
Yeah. Brugada
There is,
criteria.
sorry, sir. I don't know if this disturbing everybody, because there is a very noisy, echoic sound. You cannot really hear anything. I don't know if that's just only.
Maybe it's from my side.
For me or for the rest. Okay, now it is a stop. Yes, it's okay now. It is fine. The sound now.
Okay, if you want to analyze patient the ECG wide course complex tachycardia, try to apply Brugada pattern, which is usually for the steps. Step number 1, look for concordance. The concordance, the meaning of concordance, either positive from V1 to V6 or negative. If you look to the V1, V2, and the V3 is negative, so there is no concordance. So this is out. This is step number 1. So the concordance either positive or negative. Here there is no concordance, no concordance positive nor negative. So it is neither here. Number 1, it's out. So possibly Sveti, so look to the AV dissociation. We find there is AV dissociation. It is clear here. If you look to the 5, lead 2, and AV1, it is clear there is some B waves, a discernible B wave, and the other, we can't appreciate others, other B waves and other beats. So this is AV dissociation, which supporting the VT. The third things is the Brugada sign, which is calculated in the rhythm strip from the beginning of the R to the nadir of the S. This duration calculated, if it is more than 100 milliseconds, likely this is VT, because the VT is originated from the ventricle, so the conduction and the formation and formation of the impulse and conductivity of the impulse through the in the VT or BVC usually runs in the myocardium. So it is very slow rising, very slow initial part of the QRS complex, very slow. So we will find initial part of the depolarization more than 100 milliseconds, which is supporting the VT. If not, look to the morphological criteria. Morphological criteria, if the patient, if right bundle or left bundle, if it is atypical left or atypical right, likely this is VT. Okay, these are criteria. And other criteria, which is a very key, which is usually dominant R in the AVR, and there is other criteria. Also, you look for something else, which is northwest axis. The northwest axis, usually you will find all of the inferior leads negative, and you will find the AVL and the AVR positive, which is usually extreme axis. The other criteria, as you mentioned here, the fusion beat, as you see here, and also the capture speed. These are supporting the hypothesis of VT in this ECG. Actually, this is very nice and beautiful ECG, capture most of the criteria of the VT in one ECG. Are there any question on this stage? If not, we will keep going. Anyone have any question? Okay, so yeah, Mubarak or anyone, this VT from where this is you should know what mentioned. This from where this is extra stuff. The question is extra now. If you look to the V1, if V1 is positive, R positive, you initiate R positive, as you see here, this means this is coming from the left. So this is VT coming from the left ventricle. Thank you. Anyone can answer this question? Read it and answer the question.
Okay, can I take it? Question number 20. My name is Hassan.
Yeah, go ahead, Hassan.
20.
Yeah, go ahead.
25 years old man presented to the hospital with a rapid onset of palpitation. The lead or the lasted for approximately 10 minutes and were associated with dizziness. No documentation of sustained arrhythmia was noted on monitors, but he is noted to have frequent premature ventricular contraction of RPB morphology. The recent image show.
Actually, there is some mistake here in this question.
Okay.
It is a left bundle branch block morphology, huh?
Yeah.
There is mistake here.
Yes.
This is ventricular contraction of the left bundle branch morphology.
Yeah.
Okay.
So we saw
this is
MRI.
features.
The
This is
features.
MR,
Yeah.
cardiac MRI, short axis showing this is right ventricle and this is
Yes,
left
yes.
ventricle. Okay, we'll show you the options.
Yeah.
These are the options. This constellation of finding is most consistent with Anderson-Tawil syndrome, Naxos, Brugada, CBVT, or Carvajal. So let us go back to this to the question. The ventricular contraction if left bundle branch morphology, not right bundle branch
morphology. Yes.
Yeah. So what do you think, Hassan?
Yeah. Hassan, yes. This is a Naxos syndrome. Naxos syndrome is a right ventricular cardiomyopathy.
Arrhythmogenic right ventricular dysplasia. Excellent. What are the features here supporting your hypothesis?
So this is a skin rash on the in the back of the neck.
Okay.
Keratosis.
Yeah, excellent. It is not a skin rash. It is the what?
Woolly hair.
Yeah, woolly hair. Yes, ahsant.
Okay.
Woolly hair. Look at this hair. Woolly hair. And what else, yeah, Hassan?
And in the MRI there is a right ventricular.
Yes. If you dig carefully, I am not that much expert in the cardiac MRI, but if you look, there is a whitish materials within the wall of the RV of RV. So this is a fatty infiltration of the right ventricle. What else? Also, there is BVC or some runs of BVC, which of left bundle branch morphology, which is usually the left bundle is originated from the right and the right bundle originated from the left. So as you mentioned, this is Naxos syndrome. Does this syndrome can happen in the left ventricle or not?
Can happen in the left, yes.
Can happen in the left ventricle, and we can call this is Carvajal, huh?
Yes, Carvajal syndrome. Yes.
Excellent. You can read about this syndrome in these slides, and you can read it in your own time. Thank you.
Thank you.
Okay. This is hemodynamic tracing from our cath lab. It is homemade. It's not from the internet. So please, can anyone read the question and analyze the tracing, please? Anyway, anyone? Or I can analyze this by myself, but I try.
Okay. Which of the following?
Who's
I am
this?
Ashwaq.
Go ahead, Ashwaq.
Which of the following maneuver can elicit this phenomena? Valsalva, norepinephrine infusion, isoprostol infusion A and C, A and B.
Okay.
This
Let us go through the tracing and analyze it. Yalla, go ahead.
This is simultaneous hemodynamic tracing
Excellent.
between LV and aorta.
And
Scale
aorta is
0 to 200.
Excellent.
There is ECG.
This is the ECG and showed sinus rhythm.
Sinus rhythm and ectopic.
There is, what is ectopic?
Premature ventricular
Yes,
ectopic.
please. This ectopic, it is just general.
Yes.
Where you should specify what is ectopic, which from ectopic from where?
From the ventricle.
Yeah, ventricular. There is compensatory pause, wide QRS complex, ugly, so from ventricle. So there is BBC. So sinus rhythm, BVC, scaling, intracardiac tracing, hemodynamic tracing, scaling between the aorta and the LV, scaling from 0 to 200. And
there is systolic gradient
this tracing showed?
The systolic gradient between LV and aorta.
Excellent. There is gradient between the aorta and the LV. Okay. There is gradient. Okay.
Which increase after BVCs.
After BVC, this gradient is shooted.
This is broken. This phenomena is broken.
Broken bro.
Brown. Yes.
So indicate what?
Hypertrophic obstructive cardiomyopathy.
Why not fixed aortic stenosis or subaortic membrane? There is gradient. There is shooted high gradient post BVC. There is even in the aortic stenosis, fixed aortic stenosis. There is post BVC. There is increase in the aortic gradient.
If the pulse pressure is increased after BVCs, this indicates aortic stenosis. If the pulse pressure is low, indicating hypertrophic cardiomyopathy.
Excellent. So here, if you look to the beat before the BVC, you will find the pulse pressure here is higher than post BVC. Post BVC, the pulse pressure is small or low, lower than pre-BVC, and also the gradient is so shorted high, very high, sky high. So what other features here supporting this is likely HOCM? You mentioned most important things and needs to finish this to conclude to the answer.
Yeah, decrease pulse pressure after PVCs.
This is finished, already done?
Yes.
What else? Okay. If you look to the configuration in the aortic tracing, you will find there is spike and doom. Spike and doom. Spike and doom. So spike and doom due to dynamic obstruction indicate this is dynamic obstruction, likely HOCM. Gradient could be aortic stenosis or HOCM, but there is post BVC, there is augmentation of the gradient with low pulse pressure. This goes with HOCM. So this is broken bro phenomena. Excellent. So from this, which is the best answer?
A.
From this, so A, huh?
Valsalva.
Okay, Valsalva will elicit this problem. Yani will elicit this phenomena. Yes. Anything else from this? If you understand the pathophysiology, you will not forget it.
A and C.
A and C.
Excellent. A and C. Who's this?
Yes.
Excellent.
Yes.
Who's this?
N.
حسن ولا مين ولا معاوية؟
مبارك.
مبارك. طيب يا مبارك, why A and C? Why not A and B?
A and C, any action decrease albonus retain and decrease the preload and afterload can increase the obstruction.
I couldn't get your
Yes.
Your voice is so faint.
Yes.
Can you raise your voice a little?
Yes.
Raise your voice.
Yes. Yes. Valsalva can decrease albonus retain.
The Valsalva can increase or decrease.
Decrease.
Increase high.
Yes.
يعني, okay. So
afterload. Decrease the afterload.
Okay.
Yes.
Okay.
Any action
So decrease the afterload. Okay.
Decrease
What
the
else?
preload or afterload can exaggerate the.
Okay. Yes. I have work to do. So
yes.
The Fatsava maneuver. Do you know what is the Fatsava maneuver?
There is 4 stages of the Fatsava maneuver.
Yes,
Stage
I
one,
show
two,
you the
three.
slide. Did you see this slide?
Yes.
Okay,
Yes.
I will explain to you the Fatsava maneuver. It is very basic stuff, but very important.
Yes.
Okay, in the Fatsava, when you do Fatsava physiologically, the change will happen in the blood pressure and the heart rate is very important, and it is related robustly with what happened in the HOCM and other pathology. If the patient is taking, we have 4 stages for Fatsava. The initial stage, which is inhaling, which is increased intrathoracic pressure, leading to the squeezing of the blood in the pulmonary circulation to the left ventricle or the left side of the heart. That's leading to the push of the blood initially from the left side to the whole of the body. So you will find there is high pressure initially, as you see here. On the other side, if there is high pressure, high blood pressure, this is affecting the baroreceptor, carotid baroreceptor, leading to decrease of the heart rate. This is in phase 1. With maintenance of the Fatsava maneuver with maintenance phase, the venous return will decrease because you already squeeze the blood from the pulmonary circulation to the left side of the heart. So when it is decreased, there is decrease of the cardiac output. So what happened? The body will react by increasing the heart rate and peripheral. After a while, there is peripheral vasoconstriction. After you release in the phase 3, you release initially this Fatsava, release the pressure. Initially, there is drop on the further drop on the cardiac output because still there is remnants from the maintenance phase, and then the venous return will come back to the heart. This is leading to what? To the maintenance of the blood pressure and heart rate at the same time. In the phase 4, after the relieved stage, the blood venous return come back to the left side of the heart, increasing again, and the heart rate return back to the baseline. These are the 4 stages. So what's happening in the Fatsava maneuver during maintenance phase? During maintenance phase, in the HOCM patients, the venous return will decrease, and the left ventricle size will decrease. So a gradient, then will be dynamic obstruction across the LVOT, leading to the increase, the gradient and shooting of the pressure across the LVOT. This is the reason. During the Valsalva, there is only 2 murmurs increase during this Valsalva, which is the maintenance phase, which are what?
Hookam and mitral valve prolapse.
Excellent. The 2 murmurs, the hookam will be louder and the mitral valve prolapse will be longer during Valsalva maneuver. This is very basic stuff and very important. So this is number 1. What about norepinephrine? Norepinephrine, the role of the norepinephrine will increase the heart rate and increase the afterload. If you increase the afterload by the vasoconstriction, peripheral vasoconstriction, leading to what? Leading to the increase. If the afterloads increase, the pressure across the pressure across the pressure across the LVOT will be dropped because it is overcome by the pressure from peripheral. Blood pressure is high, peripheral resistant, peripheral vascular resistant increase. This is leading to the drop of the pressure across the LVOT during in patient with hookam. So it is out. Isoprenaline or isopreterenol infusion. What is the role of isopreterenol? Leading to the peripheral vasodilatation and increase the heart rate. Peripheral vasodilatation leading to the decrease the afterload. If the pressure on the afterload is decreased with increase the pressure in the LV, there will be a dynamic obstruction across the LVOT, and this is leading to the augmentation of this phenomena. So this is regarding the isoprenaline or isopreterenol and Valsalva. Norepinephrine, it is not part of the play game here because it is not leading to disturb either preload or afterload. Just increase the afterload. Afterload. If it is increased with norepinephrine, this is leading to the decrease the pressure across the LVOT. So in patient with hookam, usually when we want to give the patient any inotropic support, will not give him any things to increase the heart rate, only things to increase the afterload. We usually peripherally. There is some medication just using in patient with shock, in shocked patient with hookam. There is some inotropic medication only used. Do you know what are these? What are the inotropic support in patients with hookam? Okay, anyone?
Phenylephrine.
Phenylephrine, because just increase the afterload. Ahsan.
Yeah.
Excellent. Okay. We'll finish this session with this question. Can anyone read the question and try to answer? Yes. Okay, anyone, I will help you, no problem.
I will take it.
Yes.
I'm going to read a question. Sample tracing from the EB study in a patient with neurocomplex tachycardia displays in figure. What is the diagnosis? First, sinus tachycardia, atrial flutter, typical AVNRT, orthodromic AVRT with the accessory pathway, or atrial tachycardia. On the figure, we can see the first 4 leads, lead 1 and 2 and 3 and B1. And also we see right atrial tracing, his bundle tracing, and coronary sinus tracing. In the first beat, obviously we see an AHV consequently after a stimulation of S1. And the first beat, this is a stimulation, stimulation beat with in the coronary sinus. Obviously it generates an AV, and there is a very long V. After the first V, there is a prolongation of more than 500. The second one, it's an it is an atopic or stimulation in the not in the exact time. That's lead to the jump of AHV more than 300, and then A wave came in the third one between H and V, which means a retrograde A wave conducted from the AV node to the atrial. So this picture most probably consistent with the typical AVNRT. With
excellent. طيب, okay. Let us talk a little bit in details about the tracing. Look at this. This is the tracing. Usually we did it in our AB lab. This is the heart. Okay. This is usually REO view. This is a right atrium. This is a right ventricle. This is a His position and the AV node, and then His position. And this is coronary sinus in this place. These are 3 catheters. Usually we put catheter on the high right atrium or right atrial appendage. The other catheter either at the level of the His, and the catheter and the coronary sinus, and the 4th one on the RV apex. Each one of these can reflect the electrical activity at its place. This is a still frame pictures. This is, as I mentioned, this is high right atrium. This is His. This is His. Sorry, this is RV, and this is coronary sinus. This is LAO position. This is the His, and this is high right atrium. Sorry, this is coronary sinus. This is high right atrium, and this is the His catheter, and as well as this is the RV and the RV, because the RV in front of you in the LAO picture. What is reflected? This is the surface ECG. Usually we take 2 or 3 or 4 leads, and this is the surface ECG. P wave, QRS complex, P wave, QRS complex, P wave, QRS complex. The high right atrium reflect just atrial activity, which is reflecting here in the high right atrium, which this is local activity from taken by the high right atrium catheter and depicted here, annotated here. Okay. What about the His? After the conduction of this beat conducted to the AV node and then His. This beat is the A. If you
trace it, it is the A. Then will be, there is a spike. This is spike. It is his potential. After the his, we'll conduct it down to the ventricle. So A, this is the A, which is this one. This one is A. Then H, which is reflected his. Then V, which is the ventricle. So A, H, V, which is reflect the BR on surface ECG. Again, this is his, this is A, then his, then V. This is the normal conduction and in the sinus rhythm. And RV reflected just RV activity. Okay? If you collect it together, this is the surface ECG and this is right high atrium. They are these two beats, and this is coronary sinus. Coronary sinus from 9-10 to the CS1 and 2. 9-10 usually, this is the coronary sinus. If you look to these black dots, this is reflected the bipoles, the multipolar catheter coronary sinus. The distal one, which is at the level of the left atrium, it's 1, 2. The other 3, 4, 5, 6, 7, 8, 9, 10. So 9, 10 proximal to the septum and the AV node, and the 1, 6 distal from the AV node, and it's usually around lateral part of the mitral annulus. Okay. The conduction usually started from high rate atrium in sinus rhythm. This is tachycardia anyway. So from sinus rhythm, conducted from up, down, as we mentioned, to the his. From the his can be, if we recorded coronary catheter, will be proximally, usually it's received the activity first. So the first activity here is 9, 10, then followed by 7, 8, followed by 5, 6, followed by 3, 4, and lastly with 1, 2, which is usual pathway. If there is any tachycardia, as you see here, there is tachycardia here on the left side, on the right side of the screen, as well as in the left side. The conduction, the first activity here, usually there is no B wave, clear B wave in the surface ECG, but if you look to the intracardiac tracing, the first activity here is the RV. So the RV, when the activity goes from the RV to the atrium, because it's the re-entry circuit, after the RV will go usually to the his. After that, from the his down to the coronary sinus. The coronary sinus, usually the first is 9, 10, and down to the 1, 2, and then after that to the high right atrium. This is the way called concentric conduction. Concentric conduction. Usually concentric conduction happened with AVNRT. If the conduction, as you see here, from the V, the first atrial activity after the ventricle, if you look here, you will find that 1, 2 is the first atrial activity. And then 3, 4, 5, 6, 7, 8, 9, 10. If you look at the screen here, if the ventricle here is activated, and after the right ventricle, the first activation in the atrium, we find it in the 1 or 2. That's mean there is something here able to conduct the ventricular activity not through the AV, not through the traditional way, but it's through the alternative way. Usually through the accessory pathway, usually through the left lateral. And this is called eccentric Va conduction. This eccentric Va conduction usually with accessory pathway, right or left lateral. So let's go back through the tracing. If you look to the initial piece, this is the surface ECG, and there is atrial pacing from the high right atrium. If there is atrial pacing, there is A. A will conduct it also to the Hess, then H, Hess, A and A of the Hess, and then Hess potential, and then V. This is usual. Again, another pacing happened here. The same A, H, V. Other pacing which is so early, leading to the activation of the atrium, and there is in the Hess there is A, as you see, but the H, where is the H? The H is so far away from her, which is here. So AH, which is very prolonged. That's meaning this beat, which is ectopic beats, premature atrial ectopic beats, is went through, so went through the slow pathway. If went through the slow pathway, you will find it very prolonged AH. After that, if you reach the H, it conducted from H again through the fast pathway to the A, up and down to the left, to the ventricle down. So from the Hess up to the A and down simultaneously to the ventricle. And this is initiated the tachycardia. This tachycardia, list of tachycardia, if you noticed, you will find the V, A, V, V on the same line. If you find it in the same line, concentric like this, with very short VA, VA very short, this is typical avian artery. Are there any question about this at this point? Any question? Is it clear?
Yes, it is very clear. Thank you so much, Dr. Saleh.
Okay. Okay, I think we can stop here. Okay, we can finish these questions next time, inshallah. If you have time, we can do some basic stuff about the pacemaker and the ICD. So I will conclude. Good luck in your exam, inshallah. And thank you again, Dr. Hatem, for making this available.
Thank you so much, Saleh. Yeah, thanks a lot. Thank you, all of you. And I think that was a great session for sure.